US dollars or 125,000 US dollars, which amounts to something like 80 lakhs of rupees in India. So that is the amount they get. Insurance covers it, the government covers it, and each hospital which is not an ECMO center is a nursing home. So they struggle to become an ECMO center, but that is the logistics there. If I go to east and look at Taiwan, the government has inducted ECMO into the national health program. Everybody requiring an ECMO is given a free ECMO treatment because that is inducted into national health policy. So a country like Taiwan, smaller than the size of Maharashtra, can have that much of insight, then that they can make it that much feasible to have an ECMO. Why can't we do it? If I go to Europe, there they have separated the concept of a ECMO department, ECMO specialist, and they have incorporated ECMO like any other machinery in the ICU, like a CRRT, like a maybe ventilator. Similarly, ECMO is part of the machinery system of an ICU. A patient in ICU get 2,000 euros per day, whether the patient is on 10 machines or no machines. So they have to do a ECMO program within that fund. So there is no extra burden on the machine, on the system. So that is how logistics in each country is different. And we have to solve our own problems. Nobody else is going to come and solve our problems. Our state policy or government policy, our patient paying capacity, our insurance companies, and our accuracy, our acumen, that will determine the final ECMO logistics. So if I have to say the wide spectrum, like if you have to think of the best, then everybody should be traveling in Air Force number 1. Everybody should get treated only in the military hospital of Peninsula. Nobody should be born in Africa or India. You have a spectrum. Each thing has a range from 1 rupee to 10 rupee. There are shades of everything. Similarly, we have to keep a dual policy of ECMO at our center. One for poor population, one for well-affording population. So you keep all the state-of-the-art rules for rich people who can afford ECMO. For those who require ECMO and cannot afford ECMO, you have to scale down your standards. And therefore you will be able to do more ECMOs. Scaling down the standards means the range, as I see in India, an ECMO can be as economical as 50,000 rupees and as costly as 10 lakh of rupees. If everything is important, the basic machine cost, the component cost, your manpower hierarchy and their cost, and your Robin Hood to the patient, that how do you try to accommodate patient into the other things which are available from the hospital resources. So if you are wanting to learn in ECMO or you wanting to do more ECMO in your centers, there is a poor patient. If I reduce terminal, if I use the circuit, only the oxygenator and the pump, if I take a new, and I do not charge anything for me, he is charged whatever is the ICU charge and plus other medicine for whatever in the ICU, that ECMO can be done in 50,000 rupees. Because you have to, what is going from your pocket is the cost of a new thing what you are using. Rest things are lying free or are being used. You are giving your services not for the patient, you are giving the services to learn more from the patient. So if you want to become a big boss in ECMO, you have to do volume. And volume will come only when you are able to do more cases. If you are much comfortable in your own center than going to other places and doing ECMO, or going to other places and only attending conferences. So learn while you are doing, and that patient, you will make mistakes. You can afford to do some experimentation on a patient who is being supported by you. Otherwise, you are tired when you are doing an ECMO when the total thing is coming from the patient. So that way, how to make your own circuit, how to improvise will only happen when you have your own department, the cardiothoracic perfusionist who is helping you out, and you are tailor-making things, you are modifying things, and you are experimenting things. That is how you will learn.
It depends on how passionate you are.
Yes, exactly. Exactly. Many things more I have to say, but whenever phone is on line, I keep quiet. You tell me. So that is what I am trying to say, that if you ask me about logistics, simplest ECMO run can be done in 50,000 rupees. There is a spectrum of machinery from various companies. You can go for a low cost machine and can have the second best or maybe the third best scenario to run the ECMO, but that is much better than not doing an ECMO. And you can have state of the art ECMO. You always keep two machines, one lower end machine and a higher end machine. If you want to use it on a VIP patient, use the best quality machine. You charge in that way and you do a best ECMO. If you have, I will say you will only do one best quality ECMO, you will have 9 low quality ECMOs. But that is how you do it. If you take a tailor-made circuit from the company where it cannot be modified, if one component goes bad, you have to change the entire circuit. Each circuit is costing nearly 2 lakhs of rupees. That is how the machine and the disposables are taken care of. After that, if then comes the manpower. An ECMO specialist is a jack of all and also a master of all. He is a sonologist, he is a cardiovascular surgeon, maybe taking the lines for setting the techniques. He is an intensivist, he is a perfusist, the critical care nurse, he is a respiratory consultant, he can do bronchoscopy and everything. So if you are an ECMO specialist, maybe an intensivist, maybe a perfusist, the definition of ECMO specialist does not have a degree, right from a respiratory therapist to the head of the cardiothoracic department. Anybody can be a ECMO specialist, provided he has that much of experience. He takes care of everything, he coordinates everything, and he initiates things when the things are requiring an emergency input. So if you wait for the consultant to come, many times it will be too late. So as an ECMO specialist, if you are the person behind the entire scenario, then you have to train yourself in everything. And if you do that, you will save on the consultant charges. If there are 10 consultants coming and visiting a patient for an ECMO, the nephrologist, a neurologist, a pulmonologist, the cost of consultant will exceed 25 to 50,000 per day. So that way you have to be alert. You can call him when needed, but more than 50% of the time, your own wisdom will help you. Then the investigations means if I go to West and see the list of battery of investigation, the checkup procedure, I come disheartened. Daily cost of investigation exceeds 1 lakh of rupees. If I go to the East, they say do ECMO, forget everything. Just keep the machine running. That is, if accidents happen, the patient was bound to die 5 days earlier. He has died now. If you do not have the resources, if you keep things, if you use things, if you use the limited resources at the wrong hour, then what about bad days? So there is a difference of pattern, how things are going on, but there are results on either side.
Minimal things are necessary like ACTs.
Yes, few things are necessary, but factor 7, factor 10, all those things, they may not be done, they don't do it only. Few things, basic things are required, that will help you. So that is what I was trying to tell you, that as we are doing ECMOs in other centers, we can support ECMO for 5 days at a cost of 3 lakhs. 1.5 lakh is the cost of the circuit, which is everything new, and another 25,000 rupees we charge for our stay and our machine for our 4 or 5 member team staying there. So that is at a profit, not at a loss. So that is our cost of doing an ECMO in other centers. The same thing if I do at my center, it will be in 50,000 rupees. But for the entire cost, then ICU cost is separate. ICU cost is separate, otherwise also in other centers also. So this is how I am doing things. As I said that in transport, in air transport, if the person has to invest 5 lakhs of rupees, he is already 60% drained out. Then what he will give for ECMO? So if I save his 5 lakhs of rupees by going there, doing ECMO at a center, less than 5 lakhs I am able to give him an answer, whether I succeed or I don't succeed. But what ECMO has to consume, the cost factor, is done in less than 5 lakhs. So that is the way I have made ourselves mobile, and we try to save on the logistics. So that is, I said, more than that. More than that, again, beyond our capacity, this is what in our own capacity we can do that does not involve anybody. But multi-level support of insurance companies, social organizations, government, blood bank, professional commitment, and proper place and proper machines and time. They also involve the logistics of ECMO. What we expect from industry is that let ECMO be made as a life-saving device, and let all taxes should be waived off, so the cost will come down. There is always a special price for third world countries, the pacemakers, the valves from all these multinational companies are coming at a special price for this country. Similarly, in there also, where they have already made the profit by their patency rights, it is only manufacturing, there can be a special price for third world countries. But this is like begging. I don't want to say that we should be innovative enough to start manufacturing circuits and components in our country, but then again it goes much beyond our horizon to step into industry and manufacturing. But that is what should start happening. Then only the cost will come down. Otherwise the cost is going to remain high. Then more than that, again, as I said, I still appreciate Dr. Gupta for his innovativeness and trying and proving that yes, ECMO has been successful in Salesforce. I felt always very miserable when I was doing my residency in Jaipur that I could not save. I have saved only one patient of Salesforce poisoning of dopamine, maybe by God's mercy, but in other patients I miserably failed. And in Maharashtra I could not get a chance, but when he did it in Salesforce poisoning, I felt greatly elated that of course in our population, Salesforce poisoning patients are dying 99%. If they can be saved by ECMO, then it is a new thing to be added as a feather in the cap of ECMO technology. Similarly, sepsis, similarly MI, similarly cardiac shock. Why we talk of ECMO in the indication what others are using? We should try to think of ECMO in our own context, in our own problems, in our own solutions. If IHD and diabetes are the maximum disease process in our country, and MI is widely treated everywhere, and cardiogenic shock and dilated cardiomyopathy is a big outcome of improperly treated MI, then why can't we think of using ECMO as a ventilator, ECMO as an IVP? With shock trial, we have already seen that IVP is not that effective, and way apart all the problems related to ventilator of villi and pneumonias and everything, infections, if we can use ECMO into that subset, it will be a big change. But that will come only if the ECMO becomes economical. If ECMO, to which the starting cost is 2 lakhs of rupees in a given setup, then it will never take up. If the starting cost of IVP is 50,000 and my starting cost of ECMO is 15,000, I can always think of using an ECMO much prior to IVP as a ventricular assist device, as a ventricular unloader, which IVP never does. So for that to happen, you have to have that confidence. You have to have that skills in your hand that you will be able to run the system. And to have that confidence, there has to be volume. Otherwise, the big learning curve in ECMO. So for that, all this matters. Our logistics, the first and foremost thing is our fraternity. The ignorance and the laziness what we have among ourselves, right from advice to execution. There is a delay in every front. Even at my center, when I am doing ECMO, I am a cardiologist. I face cardiogenic shock day in and day out. I first put them on IVP. Why? Because I have to explain the relatives. I have to, from 50,000 cost, maybe if it is, I put an ECMO, people will say, what are you doing? Who said him to put on ECMO first? The second opinion to which the person goes, he will criticize me. Because of that criticism, I get afraid. Because it is not an established thing. If I use it before an IVP, people will say he is doing experimental things. If I am able to prove, by like his pilot study of Salesforce poisoning, that using a miniature ECMO, maybe putting the cannulas, but 2 liters, 3 liters cardiac output on a ventricular unloading by ECMO in a cases of a just started cardiogenic shock, maybe the outcome will be entirely different. So these are the things which we have in our society. These are our problems, and we have to first develop skills and then try to apply them to our problems, which the Western countries are not using. Western countries have already bypassed ECMO and IVP directly to assist device. The moment the patient comes in cardiac shock and they find the LV is gone, they don't wait for the ECMO. They say directly switch over to an assist device. That is what the present trend is going on. But again, assist device in India is more than 75 lakhs. The cost of assist device crosses 1 crore. I started doing ECMO because I went to Berlin in 2006 to start artificial heart and with my interest of heart failure. But the logistics was impossible. That time also the cost was 35 lakhs for artificial device and total costing around 50 lakhs in 2006. Now it has come to 1 crore. So I thought only thing, let me do what I can do. I pick up ECMO. Okay, that is a feasible thing of 2 lakhs to 3 lakhs, which I can use in my transient cardiorespiratory insufficiency. At least that 5%, 10% segment of population will be benefited. So that is how I am practicing. So the inertia, the problem is ourselves. When I came here again, many people were not, people well talented also never prophesized ECMO as an alternative. They criticized ECMO. Now gradually I am thankful to Intensive Society and Cardiac Anesthesia Society who have taken it in a big way. They have appreciated, they are doing conference, they are calling us, they are listening, they are talking. Still not doing. Still not doing. So because again in doing what comes? The logistics. It is not a one-man team. It's a group, it's a teamwork. There has to be a God for that. Dr. Poonam is online. Any idea?
She is coming in 5 minutes.
5 minutes, okay. I had many more slides to tell you the organization of ECMO team, but it is a teamwork. Because if an intensivist or a professional thinks of going an ECMO, the initial cost, then the hospital has to absorb the setbacks of doing a bad ECMO in the initial learning phase, the learning curve, and then to keep up the library, to keep up your inventory, and then to have the things done in the right time, and then to absorb the delays in payment and all those things. So you require a godfatherly attitude from the administration to do an ECMO when you are sitting in an institute. Fortunately, I was on my own, I had nobody on my head, so I can take up that decisions in split second, so I could do more cases. But sitting at an institute, there are many more hurdles. So therefore, why Narayan Goyal is doing so many cases? Because Devi Shetty has said no extra charge for ECMO. They have modified the cannula, the circuit. If the patient is on bypass and is not coming out, the same circuit is utilized with the same oxygenator. For the whole time even the oxygenator works, and they give ECMO as a free service if the patient is not coming off bypass in a pediatric post-cardiothoracic shock syndrome. That is what is required. Therefore, they are doing so many ECMOs because if no additional cost, no inertia. People will say, go ahead. Why All India Institute is doing so many cases? State is sponsoring it. There is no charge to the patient for ECMO. Therefore, they are doing so many cases. Somebody who asked me that what are the high volume centers? The high volume centers are those where the ECMO is free. If there is a cost of ECMO, it cannot be a high volume center. So if we are running from pillar to post because whichever centers they are able to afford ECMO, we want to learn from that case. So therefore we go to many places. So whoever is wanting to start an ECMO program, he will always have a difficulty. My solution or my advice to such people is that work out the logistics, have 2 tier system, advanced center, minimum center. You keep a program for poor people and rich people. You find out the case, call people who are experienced in ECMO for first initial 4, 5, 6 cases. Seeing is learning, to see how they are doing. That will solve at least 90% of your mistakes. With that, you will be gaining confidence. And then another 10% should be communication. ECMO world is a small world. People are very keen to give advice. It's the best part. In a bad case also, I am sitting in here, maybe it is Tom Herrick in Ohio University, or whether it is Xing Chuan in China, or whether it is someone in Dubai or something. Whenever I call him, this is happening. Like we had a problem of swine flu cases in 2009. It was taking a lot of time. Means cases exceed 50 days, cases exceed 61 days, cases exceed 1 month. Then all these cases were required. There are very thick secretions in the trachea. Well, for 1.5 hour of chiseling, we were able to remove the concretions in the trachea for only 2 inches. So that time we talked to Taiwan. This is happening. This patient would just not make it. They said have patience. They behave this way. They will take time. They will come out. So keep communication. Talk to people who are experienced. They are more interested than you are asking them. They will call up what happened, what happened. So this is the beauty of ECMO world. Everybody is interested to give you advice. Means the ILSO society is so considerate that whenever we have a conference, they come on their own. They don't charge for their travel and everything. They want to contribute to science of ECMO in India. They come on their own. Every conference they come on their own. Why should they? We made a regional this thing. So do ECMO, keep in touch, contact people. They will be able to guide you. This is how you will be able to tide over the initial learning curve. And you will face problems as you do more difficult cases, you will be able to do better. Start with simple ECMOs. Start with respiratory BV ECMO, which are simple and coming out. That will help us to boost your morale. Then you can step into difficult cases like sepsis, like ARF, like cardiogenic shock. Tackle them later on. Pediatric cases are rewarding, muconemascular syndrome, but now they are not coming much. It's a separate issue. Other more challenges like again organ transplant and ECPR and LECMO, these are other cases. But you will step into them once you have done a few respiratory cases. But minimum 25 cases is a must before you will be able to call yourself a confident ECMO doer. That is required. So other things are we have to advertise, find yourself an ECMO daddy, ECMO godfather. Always say yes before you say no. Adults are difficult patients. Asking for forgiveness is easier than not doing anything. So this is what was the statement given by Robert Bartlett. Establishing an ERC program from adult respiratory and cardiac failure, which was a more difficult case, is 10% science, 10% business, and 80% psychology. This word psychology is a great word. It means that it is your pushiness, it is your determination that you will be able to make through. Then only you will be able to make through it. So what is required in the team, program leader and other things, these things are okay. Guidelines, again, this thing is repetition. Okay, I will see you around. I can go on to next talk. Another lecture. Okay, whatever time I get, meantime let me proceed. Hello? Yes. ECMO is a bridge between a critically ill doomed life to a second chance to live across an ocean of impending death. That is very true. It gives you a chance to live, a second chance to live. A patient is collapsing in 5 minutes, he will be no more. So ECMO can help you to give some chance to fight back. And ECMO is a fusion between man and machine. In ECMO there are 3 levels: ECMO amateurs, ECMO professional, and ECMO stalwarts. An ECMO amateur is a 50% perfusion and 50% critical nurse. She's online. I'll stop here. Dr. Poonam Malhotra is a cardiac anesthetist at All India Institute of Medical Sciences. She is a key figure in promoting ECMO in Delhi and around, and she is a very good friend because in every conference she has always participated and always promoted ECMO. And she being a cardiac anesthetist, ECMO program is well established in Indian Institute of Medical Sciences. So she is doing a lot of work, and she has also published a book on ECMO, and